Alright, ladies and gentlemen, we now begin with our first panel discussion focusing on health insurance and government Yojana dynamics. I request and welcome our moderator for our first panel discussion, Dr. Biren Chauhan, Group COO, Sunshine Global Hospital, to please join us. Let's give a huge round of applause. And I once again request all our panelists to please join Dr. Bharat, Dr. Simmardeep, Dr. Hemant Bhatnagar, Dr. Abhijat Sheth, Dr. Mehul Panchal and Shri Vikram Pagaria. May I request all our panelists to join us?
Good morning, everyone. It is absolute privilege to moderate this distinguished panelist for very important topic touching upon the insurance domain as well as PMJY domain. And we thank Mr. Vikram Pagaria, sir, for gracing this occasion. So before we start, I would like to ask each of the panelists to reflect on few important aspects of insurance domain as well as the Ayushman domain. Let us start with the insurance domain. As a healthcare providers, what are the key challenges that we face as a providers and what could be the probable solutions? Can I request Dr. Bharat Gadhavi to...
Hi, good morning, everybody. First of all, congratulations to the team, Hokon, who has organized a wonderful event and has given us the opportunity to be participating in this panel discussion. Insurance, I think, is still, health insurance specifically, is still taking baby steps. And there is a long way to go. Multiple challenges. First of all, the regulatory body, IRDA. IRDA is supposed to regulate the insurance sector, but they have not bothered to take all the stakeholders on board. Like hospitals are not at all represented in IRDA, which is a major issue, because if you want to really expand health insurance, you need to take the healthcare sector, specifically the healthcare providers, hospitals, nursing homes, on board and listen to them. We have multiple times represented. There is nobody, there is not even an acknowledgement. For almost 4 or 5 years, we have been constantly writing, no response from them. So if the regulator is not taking things seriously, the sector cannot progress. I hope the new person who has joined, he has taken some actions and they will take hospitals on board. The other aspects that the insurance, health insurance I'm talking about, should look at is to separate out the professional part and the hospital part, which is usually the norm in most of the Western countries. Because you cannot club everything. Hospital rates may be fixed for most of the things. Of course, depending on the bed category, there will be some changes. But professionals, there will be a huge difference. Somebody who has just passed out or someone who is 30 years of experience, the charges may be much different. So that needs to be taken into account. We already represented that through Gehna. However, I don't think the people sitting there still have that kind of knowledge and attitude to make changes. Of course, such forums, if you bring out a white paper, send it across to them, it will make a difference. Insurance companies, specifically government insurance companies and private also are following in the same footsteps. They are not bothered to renew the charges on a regular basis. You all know that medical inflation is almost at 6% every year. Now, if you keep the charges for 3-4 years, same charges, hospitals also will lose interest and may not give the same priority to insured patients, whereas they actually should be given priority because they are paying a fixed amount as premium every year, and it's the responsibility of the health insurance companies to make sure that their interests are taken into account. Somehow, because of the apathy of the insurance companies not reviewing or not making changes in the charges of the healthcare facilities, they are actually letting the hospitals go away from the insurance. Many of the hospitals have actually stopped, and many in past also we have also given a call for stopping cashless, etc. There have not been much solutions. Tata AIG, we have already given a warning. They, without any kind of response from the hospitals, without any kind of discussion with the hospitals, one-sided, they have delisted, excluded 3,300 hospitals of the country. Now, this is something very serious. How can you do it? We are a democracy. We are not China or any other country where a dictator's role is more important. So such things, such unilateral actions, unless they sit together, then only this sector can expand. Of course, the major challenge is when people are taking insurance, they usually take only when they develop a disease. So either when they have hypertension or diabetes. So that creates a huge problem. The insurance sector works on, out of the 100, if 10 people fall ill, the 90 are, the subscription from the 90 is taking care of that rest 10. Now that doesn't happen. Out of, like if you take example of more than 50, I think 70-80% would be taking the insurance in a period of 2-3 years. So these things also need to change. There has to be some specific laws to be brought in for insurance frauds, both by healthcare sector, insurance, general public. This requires some regulatory efforts. Government has to get involved to make sure that these things are brought in. Then only the sector can improve. Otherwise, it will go on like whatever it is going on. Thank you.
Thank you. Dr. Simmardeep, as you lead the Sterling Hospitals team, what do you foresee as probable challenges from the insurance domain and the solutions?
I would like to address this issue in 3 short points. Number one, as hospital operators, all of us must come to terms with the fact and realize that the credit business, as we call it, is here to stay and is here to increase. So while, as Dr. Gadhavi mentioned, at times somebody gets blacklisted, we pull the plug on someone, this can keep on happening. A large chunk of our revenue is going to come from credit plans. This nobody can deny. So we must be prepared for that. Point number 2 is, most of the insurance companies, starting from or credit payer plans, starting from a PMJY to insurances, to corporates, to the GIPSAs of the world and the TPAs, there are issues regarding tariffs and rates and price points, for which a battle is going on. Different states, different associations, at different points in time is having a battle somewhere or the other. At times we win some battles, at times we do not. But so that I foresee as a constant challenge. There won't be a day, let's say 5 years from now, when we would turn around and say, okay, it's a great situation to be in. So we must prepare, ye chalta hi rahega. And our job is to be joint and make sure we get at least a realistic price for the kind of money all of us are spending on patients for those payer plans. That's point number 2. Now, point number 3 is also a point where there is a bit of a self-reflection as far as we are concerned as healthcare providers. You know, if we start auditing our billing, if we start auditing the way we send invoices, I think there's a lot of scope for improvement in that. If I were to take a case in point, let's say the Yojana, some of the hospitals who are empaneled with PMJY, if we have a very stringent control mechanism on what we are doing in terms for billing, deductions come ho jayenge. Same applies for corporates. What happens is right now, while we say, ji, ek saal ho gaya, usne mere paise nahi diye, but when we go into the depth of that 1 year, there are multiple back and forths. There are instances where we've billed wrongly, the bill comes back, there's a medical report which has not been attached, and that back and forth also takes time. So in this 1 year of a lag, if it was to be a 1 year lag, I think 40% of responsibility also lies with us. So the point I'm trying to make is, point number 1, we've accepted the fact that this is a marriage. The healthcare providers and the credit business, this is going to stay. So if we want to have a peaceful, nice, conducive marriage, point number 3 becomes very important. that we do our billing very, very judiciously, appropriately, in a proper audit-driven fashion. And we at our organization, Sterling, have seen that whenever we start initiating such a things, money starts coming in far more easily, deductions reduce, and life becomes relatively simpler. I'm not saying life becomes hunky-dory, life improves it. So that's my 3-bit advice on the way it should be done.
Thank you. Dr. Hemant Bhatnagar, I would request for your comments.
So I will put it from the patient perspective. And so I would want to put it in the patient's perspective. The basic question what Biren has asked, that the key challenges faced by the insurance or the hospitals these days, and what are the probable solutions specifically. Categorically, if you see the health insurance or all the problems, why, if you have to go into the root cause, why these problems are happening. If you see the trio of the entire ecosystem of health insurance, on one side we have the service provider or the hospital. On second side, we have health insurance companies or the insurer. And the third is beneficiaries or the patients. What is happening that insurance companies don't trust hospital. Hospital don't trust insurance company. And patient don't trust both the agencies. And everybody is trying to take the advantage of each other. Do you agree with me or not? That is the scenario which is happening, and that is the root cause for all the problem which happens practically and daily in hospitals. We witness that a dissatisfied patient moving out of the hospital at the time of discharge, cribbing about his bill, and delayed discharge time. Specifically, if I had to ask, one is the authorization or the time taken by the insurance company in terms of processing or approving the initial authorization process for the patient. Patient is admitted, waiting for the surgery, but the hospital can't proceed because the insurance company has not given the approval. And that delays the overall treatment of the patient. Secondly, despite of all the approvals or initial authorization at the time of discharge, that comes a surprise to the patient when the hospital asks for the co-payments or additional payment which patient need to shell out, despite of having the cashless policy. Now the mindset patient while buying the policy goes, cashless means मुझे एक भी पैसा नहीं देना है hospital में. But when a hospital asks for the co-payment or the deductions, it's a surprise to the patient. That too after 8 to 10 hours of delay, because your claim is processing back end by the insurance company. There are queries generated. There are different, and it goes to the extent, and there are a lot of hospital owners here, and I'm also attached to one of the local WhatsApp group where daily such kind of messages keeps on coming. Such and such non-medical person has come and they have raised the query, was this treatment was actually necessitated? Was this treatment actually required? I mean, they are questioning the very necessity of the treatment or the medical procedure done to the patient. I mean, it goes to that extent, so that the trust factor among these three agencies, which is kind of very depleted, that is the core reason for all this problem. Now, solution to this could be, if I have to summarize very quickly, one is that the recently what Narayana Hospital has tried to come up, and Dr. Devi Shetty has very recently announced this, that if a patient right now buy a health insurance policy, and after consultation if doctor says you require a bypass surgery, the first question comes to the mind of patient, is it actually required? Or it is only hospital is trying to make some money? But the case or the equation will be diverse if the hospital become the insurance provider as well. And that's how the very inception of Aditi Narayana Insurance, which is going to have a sandbox project in Mysore in this month, the whole equation get changed. And patient won't have that distrust that the procedure or the surgery prescribed by the doctor, ultimately it's the hospital who is going to be paying for it. So it is actually necessitated. Point number 2, staff education and training is also very practical answer, because there are instances where at the time of billing, if the codings are not done properly, even the hospital gets kind of deductions and delay because of that. These are the two things. And third is definitely your reputation in terms of trust and transparency of the billing, with the insurance company also plays a major role in terms of overcoming these challenges. Thank you.
Yeah. Thank you, Doctor. Dr. Abhijat,
Thank you. I will be more as a director of medical services, and what day-to-day problem we faces with the insurance that I will mention. Couple of important things. The one is already been shown by our colleagues, that complexity of these insurance claims has been made so difficult. Previously, it was between the company and directly with the hospitals. Now you have company, PSUs, TPAs, and the primary people who are going to get an advantage of it. Hence, the complexity has increased, the bureaucracy has gone up with this, and this all eventually results in a delay in the decisions, delay in the claim processes, and dissatisfaction on the patient side, irrespective of the base job, clinical job, and clinical outcome you have done with the patient. That is one. Number two is we have to understand that medicine is also getting the paradigm shift, that we are treating patients until now, but there is a huge shift of preventive medicine has came into place. And when we talk about preventive medicine, a lot of OP class practices has started. And certainly the insurance company, if they look this with the positive set of mind, and these days you have a artificial intelligence type of tools, in fact, this will be hugely beneficial not only to the patient, because the biggest problem which we facing in insurance through the insurance companies is outpatient claims, and they are one of the most difficult claims to get it from the insurance companies. So if the company's focus is on this side, the preventive side, and they introduces the new amendment with their insurances claims and facilitates the operational side on the outpatient claims or daycare claims, then it will be hugely beneficial to the end user. The third important is grievance resolving mechanism. The grievance resolving mechanisms are very slow, and there is a multiple communication takes place, and many times they keep intended to slow this process, to delay the claim, which is in fact they feel that they are saving money for the company. That is not true. Eventually it harms both your customers and it harms the credibility of the company also. So this is something which they need to work on very effectively. In fact, we have already all have seen that digital format brings more transparency, more uniformity than instead of managing through the only through the human resources. If they enforce the digital submission or they enforce this mechanism more effectively, it will be highly beneficial to us. So these are the few points which I would say.
thank you. Dr. Mehul, as you are leading the trust-based hospital, what are your thoughts on the challenges and probable solutions?
Please say it again.
What are your takes on the issues faced by trust hospitals in the insurance domain and probable solutions?
Fine. So basically, as all our dignitary speakers have said, we are facing the same challenges. One of the important thing is the turnaround. the release of a payment, because many of our times the complicated payments are getting delayed, maybe somewhere around 3 months, 6 months during the time of a scrutiny. And those are the challenges where we are facing some of a crunch. Otherwise, the insurance are pretty much sailing smooth in our organizations. Thank you.
Okay. Mr. Vikram, you have listened to all the challenges and the probable solutions. Now, coming from the NHA background, can you throw some lights on the recent advancements at the IRDA or the policy level, and specifically the NHCX, National Health Claim Exchange? How these changes will going to transform the future in the insurance domain?
Good morning, everybody. National Health Authority implements the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. It is implementing it since 2018. In addition to that, it is also implementing the Ayushman Bharat Digital Mission. Both of these schemes of the government of India, they leverage a lot of technology for claim adjudication, claim processing, and all the challenges that the fellow panelists have mentioned, in addition to the delays in authorization, delays in receiving payments, these are being handled and these are being faced at NHA at a very large scale, because NHA is one of the agency which implements this scheme on a mass level. There are about 30,000 hospitalizations every day under the scheme. So quite a lot of technology prowess or technology strength, I would say, is there in NHA when it comes to adjudicating claims using technology. There are various initiatives that the government has taken, for example, the green channel payments and auto approvals, so that at least 50%, 60% of the claim amount is disbursed at the time of the raising of the claim. In addition, what National Health Authority is doing is it is working in close coordination with the IRDAI to launch the National Health Claims Exchange. And National Health Claims Exchange is an initiative which will help hospitals to reduce their transaction costs in claim submission. So from your HMIS, from your hospital management information system, you would directly be able to raise the claim of the patient for in spite of the fact that he may be from any policy. You would not have to choose. For example, there are some software which will be for Bajaj health insurance, then there is for Tata, and then there is this TPA desk where all the documents of the patients, they get scanned and that they get uploaded. So when the doctor comes in the morning and says that the patient can be discharged, but due to this manual procedure, the discharge actually happens at 4 o'clock, 5 o'clock in the evening. So how do we reduce those times? How do we make it more efficient? How do we leverage technology? We are working very closely with IRDI. There are all the insurance companies have now got their software integrated with NHCX, and we are hoping to have this pilot very soon. In addition to that, some of the thoughts that panelists raised, I would want to offer some comments on that. When it was said that there is a trust issue among the patients, hospital providers, and insurance companies, I think it's a structural problem, and that would be there. We will have to manage it, and we'll have to also learn from experiences of various countries where the insurance market is fairly mature. For example, in the US, the insurance scheme is all the insurance is the dominant partner in the healthcare space. In our country, insurance is slowly picking up. So we'll have to learn from those experiences, contextualize to our our country's population and implement them. Um, uh, in terms of OPD insurance, so even I think there's a lot of importance that we have to give to technology. Right now, the cost of claim processing is somewhere around 500 to 600 rupees per claim. If that is the cost of insurance claim processing, we'll never be able to provide OPD insurance to our patients. So if we'll have to leverage technology so that in some years from now, we'll be able to make it affordable, reduce the insurance processing cost, and so that OPD insurance is also available freely to the patient. So my overall point is, yes, technology has a role to play. Yes, there are challenges. There is a committee which has been formed under Dr. V.K. Paul, Chairman, Member Health, Niti Ayog, to review the PMJY scheme, review the packages, review how do we improve the various aspects of PMJY, and there would be revisions to it. Also, all citizens of our country who are more than 70 years of age might get covered under PMJY, and then this scheme is only going to grow, and we'll have to plug the various loopholes that are coming, and we'll have to take feedback from all the hospitals also, and for IRDA also we have a meeting on 15 July. We'll also put forward this point that hospitals should also be listen to it, but my advice would also be to coax or to nudge these insurance companies so that your point of views are also represented by those companies when they talk to IRDAI. Thank you.
For sure. Excellent. So now let's move back to the another topic of Ayushman Bharat Yojana, and I would again request Mr. Vikram to start and share his views on how the Ayushman Bharat scheme is faring in meeting its two objectives. Number one is health and wellness centers called Arogya Mandirs, and second is to provide free cashless treatment to almost 40-50% of the population of this country.
Second question, can you repeat again? Second question I did.
Second is to provide the cashless treatment to almost 40% of the population.
UHC to 40% of the population. Okay. So Ayushman Arogya Mandir was the first part of the question. So I'll again want to emphasize that there are 4 pillars of the Ayushman Bharat scheme. The first pillar is the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, the 5 lakh rupees insurance scheme. The second one is the Ayushman Bharat Health and Wellness Center, which are now called as the Ayushman Arogya Mandir. These are basically places or health centers which are in the close vicinity of the citizen, where he or she can go and get preliminary treatment. So it's basically based on preventive aspect of healthcare. The third I mentioned is the Ayushman Bharat Digital Mission, and the fourth pillar is the Ayushman Bharat Digital Mission. How do we use technology? How do we digitize healthcare so that healthcare data moves easily from one hospital to another? So right now what happens is that when you go to Apollo Hospital Chennai, and after 1 month you go to Apollo Hospital Hyderabad, all your health records would be available in Apollo Hyderabad. But suppose if you go from Apollo Hospital Chennai to AIIMS Delhi, then since they are using different software and different systems, all your health records are presently being seen as printouts. So right now what Digital Mission is trying to do is to provide a mechanism whereby the doctor asks whether I can see your previous records, and if the patient says yes on her phone, then all the health records are visible to the other doctor, irrespective of whether she is in Apollo Hospital, she is in AIMS or any other hospital. So that aspect is Ayushman Bharat Digital Mission. How is how is the PMJY helping Ayushman Arogya Mandir? So uh, uh, when the scheme was envisaged and it has been 5 years of implementation, what was thought is that this loop has to be complete. So whenever the patient goes and seeks a treatment at a PMJY empaneled hospital, after that he or she will require follow-ups. So for the follow-ups, what was envisaged is that the patient would go to the, the nearest facility which is there and get these follow-ups done. If the Ayushman Arogya Mandir does not have that facility, then the doctor may refer her to the community health center or the district hospital. So this triage system and the concept of care of continuum between various levels of the healthcare ecosystem was there in the scheme from the starting. However, we all know that schemes have their own time to be implemented. So I think in future it would take some time, but that's the spirit in which these Ayushman Arogya Mandirs would be connected to PMJY scheme.
Due to paucity of time, I would like to request all the co-panelists to share their views on Ayushman Bharat scheme quickly in less than a minute. Dr. Mehul.
When we are talking about Ayushman Bharat schemes, we are talking about the three stakeholders. One is a government, second one is a public, and the third one is a hospital provider. So when we are talking about the governments, they are doing excellent jobs. They are basically trying to decrease the threshold of a common people to access the affordable treatment. When we are talking about the public, even though I'll say that many of a good and coming from a good families, people are also having benefits of a Ayushman card. Even the government officers after 70 years of age also having a Ayushman card. So they don't hesitate to go into the any private sectors and take a treatment. Earlier they used to only go through a government hospital. So maybe approach towards the health has been changed from a typical government hospital to any government empaneled hospital, which will be also providing a good amount of a quality treatment and a good amount of outcomes. When we are talking about the providers or the service health providers, I'll say that again Ayushman Bharat has done a good job, because earlier the unutilized capacity of our hospitals were pretty much large. Now because of this particular Ayushman Bharat Yojana, the unutilized capacity of our hospitals are getting filled. Again, there is a constraint that we have to select the right candidate for a right protocols for the right particular code. So that is a little bit a crunch that I am feeling that Ayushman Bharat is having, because everything is just SOP based, everything is just a package based, in which the human behavior will not change as per the SOP or as per the package, and we have to select the right candidate and right thought. So maybe we are doing a good amount of a justice to 80 or 90% of our populations, but when we are talking about the critical illness, when we know that the outcome cannot be predicted, it is only a time base we can able to predict the outcomes, in which Ayushman requires a good amount of improvement. Thank you.
Yeah, with Ayushman Bharat Yojana is like all sorts of governmental schemes. The Yojana has delivered very good in first few years. But what happens that whatever good you do, eventually in the healthcare it becomes burden on you itself, because it increases the longevity, it increases the subsequent exposure to the health problems, and certainly it increases the financial burden to the yojanas, and this is how the most of the schemes gradually crumbles on its own pressure. Being a service provider, we want to make sure that these services which we are providing and the cost which we are receiving from Ayushman Bharat should not become a virtual money, because if it becomes a virtual money, gradually the efficacy of the organization to provide that services will go down significantly. And that is something which we need to do. Ayushman Bharat Yojana, the government will have to certainly look into a lot of innovative practices where you have a short hospital stays, where you have a quick recoveries. Many times these procedures looks costly from the beginning, but eventually on a long term it saves the government money. So these are the factors. And third is eligibility for Ayushman Bharat. There is always a claim that a lot of people who are not eligible also gets Ayushman Bharat. On the receiving side, we always feel that whosoever is coming, even with the Mercedes car for Ayushman Bharat, it is their problem, it is not our problem. We have to treat them as a patient. So this is what we do. But I think government should take care of all these issues. Thank you so much.
I'll try to give a pragmatic perspective from Ayushman Bharat, again from the hospital sides. If you see, if I share a couple of statistics, just, and I'm sure audience must be aware, in terms of availability of bed in the Indian context right now, we are still less than the WHO standard bed per 1,000 population. It is less than 2 beds per 1,000 population. It is again diversified, and kind of the distribution of beds or availability of beds is state-wise it is different. Like in a state like Karnataka and all, it is 4.5 beds available, whereas Bihar, it is 0.3 bed available per 1,000 population. So that's the parity, that's the disparity in terms of availability of the bed. Coming to Ayushman Bharat Yojana, sir, the government initiatives and the penetration and the intent to reach out to the poor to provide the quality health care is definitely something commendable. It's world's biggest health insurance company and running successfully. But when it comes to actual implementation, if you see, 70% of the high-end treatment modalities still are available with corporate hospitals or the private hospitals when it comes to transplant program, liver transplant and all. And until unless private sector don't find these schemes lucrative, when I say lucrative, I refer to one in terms of the reimbursement, because the cost which is right now reimbursed to the hospitals are not meeting the basic operational cost of delivery which are given to the Ayushman patient in corporate hospital. Second, I'm sure a lot of promoters and a lot of hospitals are also sitting in the group, and they have also gone through the same challenge, that the delay in payment or the reimbursement that disturb the entire cash flow cycle of the hospital. I mean, just on a different note, Gujarat itself has witnessed a huge pile of reimbursement in terms of Ayushman Yojana per se, for different reasons per se. But now, so that if that can be taken care well of, this scheme can be well accepted by private providers, and the benefit can be reached to the larger population. Third and most important thing, which AHPI Chairman Dr. Girdhar Gyani has also very recently submitted to Honorable Finance Minister Ms. Nirmala Sitharaman, and I have seen his video on YouTube, where Sir has requested that there should be a scientific study of Ayushman packages. There should be scientific evaluation. It is just now kind of taken and implemented irrationally or on some basis on what, it is not clear, and some kind of discontent or disconnect between the actual provider and the cost of the services which are reimbursement by Ayushman Yojana. So these are the two things I think if can be well taken care of, the actual intent of the scheme can be penetrated to the deeper section. Thank you.
While most has been said on the subject, I have only two inputs. One is my request is to the government and to the authorities that the distribution of the cards should be limited and only given to people who fall under the criteria. We've seen there is a rampant distribution or empanelment of Yojana cards by individuals who don't even fall into that criteria and don't deserve that. So what's happening is the number of beneficiaries is dramatically going up, and there is obviously a limited budgetary allocation. So this puts pressure on either the intermediary insurance company or something. So there should be a check on that. Second is my advice to all of us is we should also be very careful when we bill for these patients so that there are less deductions and less rejections. That's about it.
So I would rather summarize, as Dr. Biren said. First of all, we all accept that it's an excellent scheme, and kudos to the government. It's a large population is being taken care of by the scheme, and implementing, executing such a scheme in the whole country is definitely a challenge, and it has been done very well. Of course, like any major initiative, there will be some shortcomings, and there are learnings. I'm sure the government is also taking care of those things. One of the shortcomings or one of the challenges that the government would have to look into is some of the states, they keep on changing. Sometimes they involve insurance to implement the scheme. Sometimes they do it on their own. Whenever the insurance is involved, they look at for-profit. Now, this is not a for-profit for a middle agency. The hospitals only will have to make sure that they make money to ensure that their equipments, etc., are maintained, or newer equipments are brought in, and basic costings are taken care of. But if you involve insurance, they try to make profit out of that, and then they start following all wrong tactics, delisting hospitals for frivolous reasons, etc. So ideally, if there is a dictate from the central authority, NHA, that to all the states, that please don't involve insurance company for implementing, because there is no role. They will, if you try to make money out of the whole scheme, which is the low-cost scheme, which is like barely meeting the revenues of the hospital, it won't work. So something has to be done. We have seen in Gujarat how insurance, when they brought in insurance, Oriental Insurance, a huge chunk of payment has still not come, and the fight is still going on. I think still 200, 300 crores are pending. So this is one of the learnings. Second, as Dr. Simmardeep rightly said, that there has to be a clear-cut delineation of who can benefit. Somebody who walks out of Mercedes, owning a Mercedes, they cannot, they don't deserve a PMJY scheme benefit. So it has to be linked with PAN card. Anybody who is paying income tax should be debarred. I think this is simple. We have one of the best IT systems in PMJY, and linking PAN card to exclude the beneficiaries will be a major step in ensuring that the people who actually deserve the kind of benefits from this scheme are given the benefit. So, and it's a very simple. We have done it. Aadhaar PAN has been linked. Digi Yatra is, I think, is the political leadership they need to. I don't know why they are afraid of. It's not difficult.
Sir, on a lighter note, already income tax बहुत कम लोग दे रहे हैं, PAN card से link करके और भी कम ना हो जाए.
Exactly.
Apologies for
That can be
interrupting.
another
We're running out of time.
Okay.
We would love to take this discussion forward.
Thank you. Thanks a lot, Dr. Pagaria. Thank you, everyone.
Thank you, everyone. We will not take any questions. We all are available on the sidelines. Thank you. Thank you.
Thank you so much. Moving ahead, may I request Mr. Vikas Sharma to please join us and present a token of gratitude to our moderator and speakers who have joined us today and shared their knowledge with us. May I request Mr. Vikas Sharma to please quickly join us and present a token of gratitude. Thank you. Thank you so much, Mr. Sharma. We would like to begin by presenting the token of gratitude to our moderator, Dr. Biren Chauhan. Thank you so much for moderating the first panel discussion at HRCon today. Thank you. We would like to present a token of gratitude to Dr. Bharat Gadhavi. Thank you so much. Moving ahead, we would like to present a memento and token of gratitude to Dr. Simmardeep Gill. Moving ahead, we present a token of gratitude to Dr. Hemant Bhatnagar. We would now like to present a token of gratitude to Dr. Abhijat, Sheth. Token of gratitude to Dr. Mehul Panchal. Thank you, Vikram. Thank you so much. And to present a token of gratitude to Vikram Pagaria ji, may I request Meeta ma'am and Megha ma'am to please join us. Request, we present a token of gratitude to Shri Vikram Pagaria ji. Thank you so much. Thank you everybody, thank you. Can we have a group picture, all of you together, all the panelists and the moderator?